sort of cultural, sort of antagonistic area where we have sort of the interventional aggressive people versus the more cognitive first do no harm people, this would probably be something we could apply to CCSVI. But we have to get through the speed bump of you show me that this actually exists, you know, and that this is real. How do you know that before you even start to think about treating it, you know? That's an issue we all have, and I'm not sure it's going to be resolved to everyone's liking in a short period of time. So, obviously, you're familiar with the Zamboni criteria. Again, there were 5 criteria. Sandy, I guess, is here, who knows more about this than anyone, of course, we were involved in actually reviewing this at a meeting in Bologna a few months ago, and this may be possibly revised and even drop the transcranial portion of this. But bottom line was, when Zamboni said if you have 2 or more duplex parameters, he said this was basically diagnostic of MS. Again, that's been challenged, of course. This is a subtle, nuanced study, and as you saw from the guys in San Diego, that wasn't really on their sort of work up there, and there are good reasons for that. We're not Europe, and we're not even, we're not Canada either. I mean, where this has sort of had the opportunity to have expertise developed with this. I've taken this, I don't know how many times, to our vascular lab and tried to get people to master this unique. It's an absolute devotion, dedicated, must go somewhere, learn the techniques. It's really not something that you just legal tender stamp them out. It's probably an hour procedure if you're just getting started. There's lots of positional maneuvers you have to do. But suffice to say, in Zamboni's hands and others who are properly trained, the mean number of abnormal parameters in MS patients was 3.8 out of the 5, and the normals was 0.12. And again, this is always has to get challenged. And remember, an ultrasound is not an ultrasound is not an ultrasound. And we talked early, an MR is not an MR is not an MR. Because if they were all the same, we wouldn't have this range of 0% to 99%, or whatever that Jack was talking about in terms of how we diagnose this stuff. But you can see certain things that are, I think, undeniable in terms of not being normal. This is jugular vein, common carotid on the right, jugular vein on the left, common carotid on the left. This is encoded such that red demonstrates flow going one direction, blue in the opposite direction. This is the way it should be. Artery going up, vein going down. Here they're both red, and obviously the vein is reflux or stagnant perhaps, and obviously is narrow, small. And if you look at these criteria then, back to actual original Zamboni, he again showed that compared to a control population where, again, we have this sort of unfortunate, a lot of zeros here for a lot of these criteria. In an MS population, almost all of these criteria occurred in roughly more than 50% of patients. So what else besides Doppler ultrasound? Well, I guess you can see, again, this is where ultrasound, I think, and this is one of my patients, has, you can't, a lot of physiology, but there's still anatomy that is basically undeniable. If you see something abnormal intraluminally, such as webs, diaphragms, cul-de-sacs, valves that don't work right, then, that's, I think, pretty good evidence that there's something that's not normal. And this is a patient, this is a normal valve, bicuspid valve, and then down here, there's other valvular apparatus that no one really, again, I'll play this, hopefully you can see it. Here you can see the normal valve, but down here you see, and there's something in here as well, that is just not normal, and the end effect of that is you get basically chaotic turbulent flow. Now how that reflects back up into the brain, I don't really know, but I took a lot of our MR data and went to Caltech in Pasadena and talked with a guy there who does all the valvular modeling for cardiac valves, especially all these new transcutaneous aortic valves. And they came back and asked me all sorts of questions I couldn't possibly answer. But suffice to say, the way we're looking at flow disturbances is totally naive, Neanderthal, and primitive compared to the way these guys think all of the different measures you should have to know to really understand what the effect intracranial might be from something extracranial. Here's another. This is actually the other side in this patient. And you can see a valve here, or a valve apparatus. This appears to be a single leaflet. And when you look at this, you can see that that's not a normal valve in any way. And I could replay that once, I suppose, for you. But you can see we have a very strange looking valve. And again, many people have demonstrated from the extreme of the valve actually being upside down to, again, subtle valvular abnormalities, including valves that don't open correctly, valves that may have more than the required leaflets, etc. The end result is that sometimes with MR, we can then see the effects of it. Now, MR does not do a good job looking at the valves per se, but it can demonstrate things such as this, as slow flow, asymmetric between the sides, obviously very prominent valve cusp, but we don't really can ascribe real function to that. When I look at this, and I see the valve looking like that, I tend to get my attention, and likewise you can see on the other side a small valvular abnormality, which corresponds, in this patient, to this appearance. This is a jet, and oftentimes we can't see the jet on MR because 90% of the jet is into this vein right here, the subclavian vein, or brachiocephalic vein. It's just this little orifice here that's creating the jet, but obviously we're unable to see it in the vessels flowing into it. Here's the other side. But the real $64,000 question now is, how do we know, we see this abnormality, this lesion, quote unquote, but how do we know if it's really significant? And so we've been trying to look at actual flow and see if we could non-invasively with MR demonstrate, get at least a significant experience looking at flow, and I know Mark's done some of that, I'll share that with you. I won't go into a lot of the details about how we do that because it's a little technical, but suffice to say we measure flow in the jugulars only, high, medium, and low. We now know what normal flow should look like. We have signature traces of what that looks like. We know how the amplitude should change. We know how the phasicity should change. Again, I'm not going to go into a lot of detail about that, but suffice to say, this is going now from transverse sinus in the yellows up to the right IJ, very low down. We can see, again, these high peaks here are low, these are up near the jugular bulb and into the dural sinuses. We can map out these things, and now as we've got enough normals as well as patients with MS, we start to see some things. And here's, for example, a normal. Again, these are the low, the magenta is mid, and dark blue or indigo is high. And this is what it looks like. In this patient, we then can find the mean flows at any level. Again, I won't go into a lot of detail, but you get the idea. This is sort of an anatomic rendering, which shows fairly normal veins, as opposed to an abnormal patient like this, or the flow pattern's abnormal, and you can see, obviously, basically a inversion between the different patterns here, such that we see again, this is low, high, but these are actually flipped, and they're flipped because of collaterals. And suffice to say, I would agree with Jack that nothing in CCSVI is 100% or uniform. There's lots of overlap between so-called non-healthy, non-MS patients in terms of flows. More often than not, we have sort of called healthy controls who may have low flow. Most of the MS patients are consistent that they're low. And most of the normals tend to be higher flow. But in absolute terms, this total flow volume is much less than that normal I showed you. And here in this patient, we then compare this. The patient's head to a little tip, such that the superior anterior is the right, this is the left, and we see areas here and here in the jugulars, these are the carotids, which again correspond to very low flow rates. Anything below 0.2 liters per minute or 0.25 we consider abnormal. And now we can get this sort of scatter plot. And Mark has had a lot more experience about, he can tell you about that. Anyway, I think now at this snapshot in time, as I said before, it's moving very rapidly, so it just is a snapshot. There's general acknowledgement that anatomic renderings exclusively, just looking at the anatomy, are insufficient, limited, and often inadequate indicators of venous disease. There's a high false positive and high false negative rate.